Hem-Onc Fellow at the University of Chicago, and will be staying on at the University of Chicago as faculty starting this summer. And yeah, we're thrilled to have all of you joining us today for hopefully another wonderful case. And as always, we do need some volunteers to join us. So we need someone to present a case. And then we also need 2 discussants, ideally at least one that identifies as non-binary or female. So please, hit us with a line in the chat if you're willing to jump in the lukewarm seat. There's a case discussant or a case presenter or one of the discussants. And with that, let me flip it over to Dan. I'm also feeling some raindrops, so I'm going to turn off my video and I'm going to relocate.
Here, I was just thinking that Anand was using a really clever Zoom background, but he's actually outside, so that's fantastic. Well, my name's Dan Minter. I'm one of the R3s here at UCSF, and have been part of the clinical problem solvers since the beginning. Anand asked me to reflect for people who are coming up, about to start intern year, about what nights are like. The backstory is that I just came off a whole month of nights, and I'm a little bit worse for wear. I feel 10 years older as a result of this. But I think the interesting part, apart from having to like scrounge for food and eat like saltine crackers and whatever you can find in the hospital at night, is like how the work is a little bit different. So here at UCSF, our night shifts tend to be mostly admitting roles, which is awesome. And if I could do that during the day, all day long, every day, I think that would be like one of the jobs of my dreams. But the sort of thought process behind like risk management, I think, is kind of an interesting thing of, you're the only person who's really seeing this patient. And you may not discuss it with an attending, for several hours. So you kind of, I think, personally, what I've seen is that, if I'm admitting at night, I tend to be a little bit more risk averse than if I'm admitting during the day in terms of my diagnostic and therapeutic stewardship. And, an example might be, somebody who has like an aspiration or something, like you're pretty sure it's an aspiration. You have this perpetual question between, is it, a bland pneumonitis, or is it an infectious pneumonia? And if I'm on during the day, oftentimes, I may say like, hey, I'm going to give this some time. I think that all of this inflammatory syndrome with, infiltrates, hypoxia, tachycardia, potentially even fever, I think that this could be a bland chemical pneumonitis. Versus at night, I may think that, but where's my diagnostic sort of testing and therapeutic treatment threshold? Where are they going to lie? And, I think a lot of the times what I find myself doing consciously or subconsciously is being a little bit more cautious at night and saying like, well, maybe I'm going to get that CT scan for rule out PE. Maybe I'm going to cover with antibiotics just to, cover my bases in case the day team does feel that this ultimately is more of an infectious aspiration. Maybe that's not the world's greatest example, but that's kind of the thought process that I feel, at night of, hey, maybe I should take that extra step. And if I find myself questioning of whether I should do something, I think oftentimes that's enough of an impetus for me to say, okay, and rather than talk back and forth about the CT scan or antibiotics over and over again, I might just do that overnight. And then the day team, can sort of Monday morning quarterback. And I think that fits with a lesson that I've learned throughout training, especially when you're cross cover at night or when you're admitting at night by yourself, is people rarely will fault you for going big and being cautious, but they will fault you if you don't sort of cover something, if you don't cross that T or dot that I, and the thing that could be potentially dangerous overnight. Oftentimes they'll say like, why didn't you call GI for this GI bleed that now is catastrophic or something like that. So I think it is interesting food for thought for a lot of you who are about to start, clinical rotations and really be that doctor that's writing the orders that aren't getting double, triple checked by your interns or your residents and stuff. You guys will be the interns and residents pretty darn soon, which is, it's scary at first, but it's just like also the coolest thing coming from fourth year medical school to really being in that position of responsibility. But anyway, that's some food for thought. The other things that I obviously didn't do well is I never could get the sleeping quite right. And I'm very happy to be done with nights for residency. If I do nights in the future, I think it'll be for a moonlighting role. So that'll take the sting off a little bit. But yeah, sleep hygiene, taking care of yourself, treating yourself, and sort of giving yourself a little bit of leeway in terms of responding to emails and whatnot during your month or 2 weeks or whatever you guys do of nights. It is important. Anand, I'm not sure. Do we have folks out there, or should I keep rambling? I'm not sure.
Dan, I wouldn't call that rambling. That was beautifully put. But we do have two discussants. So we have Taylor and Dhruv, who are both discussing, going to be joining us as discussants. We're still waiting for a case presenter.
Okay.
Fernand has like kind of sort of thrown his name out there. Oh, it looks like Anne Marie has a case as well. So let's see.
Dhruv guy though, I've never heard of him before.
Yeah, exactly. No, so why don't we let our other discussants introduce themselves, let our scribe and teaching points person introduce themselves, and then based on where we are, maybe we'll have Anne Marie step into the presenting role. The one quick thing I'll add to Dan's night float reflections is I think overnight you can actually practice stewardship in a little bit of a different way, which is, when I work nights, I would think about what are the tests that I can send or the workup I can do that's going to help push diagnostic momentum kind of over those next 12 hours or so. But if it was a test that wasn't going to change management in the first 12 to 24 hours and could potentially take several days to come back, I feel like that's where I would really exercise my restraint, where I would be like, if the day team can kind of use the last 12 hours to better inform whether that send out test is worth sending, maybe that's something that's worth holding back on. So I feel like there's kind of a different avenue potentially for stewardship, where it's like you want to make sure you're covering all of the acute things that can make patients get sick quickly, but the things that may be a little bit more of a slow burn, you can certainly think about. And then, ultimately, whether you send that test at 11 p.m. or 10 a.m. the next day, usually it doesn't end up making too big of a difference.
You know what my favorite thing to do though, Anand, is to time the labs for like 9:30 or 10, or time the antibiotics for 10 or 11. So like after you sign out, you're like, well, I ordered that, but you guys can discontinue it if you want.
Dan has all of the pro move tricks, as you can see. So with that, let's have Taylor introduce herself, then we'll have Dhruv introduce himself, and then I believe Gurleen and Gabby are going to be doing teaching points and scribing for us today, so they can introduce themselves as well.
Hi, everybody. My name is Taylor. This is my second VMR. I'm a PA in internal medicine. I don't think I said this last time, but I work at Einstein Hospital in the Bronx. And I'm a really big fan of the CP solvers. Actually, one of my favorite attendings to work with, he, I think Monday was his last day, or sometime last week was his last day, and he's actually coming to UCSF. He's going to be a hospitalist, so you guys should look out for him. His name's Dr. Robertino Garcia. So I told him about the CP solvers, and he's like really into like teaching and everything, and that's really why I love this podcast and this community. So that's my little spiel.
I guess I'll go next. Although I've always heard the thing of Dhruv doesn't need to introduce himself, but whatever, it's fine. So hi everyone, I'm Dhruv. I'm a in what is it, 11 days now, going to be MD graduate from VCU School of Medicine, MCV for all the old timers, and heading to Western Michigan University for Med Peds in July. So yeah, basically trying to get my last amount of time that I would be able to join you guys on VMR at least consistently and get my discussing time in. Most of the time that I'd be doing afterwards would probably be presenting cases that I'd see in clinic. So
well, Taylor and Dhruv, we're so happy to have you join us in the lukewarm seat. Gurleen, do you want to go next? And we'll have Gabby introduce herself, and then we'll flip it over to Anne Marie, and we can kind of go from there.
Yeah, hi everyone. I'm Gurleen. I'm finishing up my last week of fourth year med school this week at Albany Med, and I'll be starting internal medicine residency next month at Brigham. So I'm really excited, and thanks Dan and Anand for all the night float trip tips.
Hi everyone, I'm Gabriela. I'm speaking from Brazil. I just finished my neurology residency here, and I will be scribing today. So thank you everyone for being here.
So with that, let's go ahead and get our whiteboard up. And Taylor, why don't the two of us join forces? So we'll work as a team. So with that, Dan, I'll let you and Dhruv decide whether you want aliquot 1 or 2.
Dhruv, do you have a preference? I can't see. I think he's muted.
I'll defer.
Okay, let's do aliquot 2 and give
Yeah, so aliquot 2 and giving you guys first crack at everything.
Cool. So Taylor, we'll tackle aliquot 1 together. So with that, let me turn it over to Anne Marie. She can introduce herself for those of you that may not have met her yet virtually, and then we can jump right into the case.
Everyone, I'm Anne Marie. I'm a first-year hospitalist at the University of North Carolina and a big fan of CP solvers. This is a case that was presented as a presentation like on a clinical unknown at UNC. So I did not specifically see the patient myself, but I thought it was a cool case. And so I will present it. And then shout out to Carlos Rubiano, who's one of the chiefs who helped prepare it. Okay, so this is a case of a 30-year-old male presenting with increased pain and swelling in the left shoulder and neck. So the neck pain is worse with extension and left lateral rotation, as well as with swallowing. It's been going on about 6 months and has worsened over the past 2 months. It also seems worsened by moving the shoulder as well. During the time, also noticed loose stools and chills. However, no fevers, night sweats, oral lesions, shortness of breath, abdominal pain, nausea, vomiting, weight loss, or headaches. So as just a little bit of background, 7 months ago was hospitalized and found to have leukocytosis in a CT scan demonstrating several small abscesses within the right lobe of the liver, and then a cystic mass in the spleen and retroperitoneal lymphadenopathy. He did receive aspiration during that hospitalization of the abscesses, and aerobic, anaerobic, fungal, and AFB cultures were negative. A TTE showed a slightly reduced EF, but was otherwise normal. Was discharged on a 4-week course of fluoroquinolones and metronidazole.
Anne Marie, one quick clarifying question before Taylor and I get into it. Did his did things resolve in the sense of those abscesses, leukocytosis, or are we not sure after that course of antibiotics?
I'll get a bit more into labs. Did not follow up after, and so this is kind of the first re-exposure with the healthcare system since that time.
Perfect, thank you. Taylor, very meaty aliquot for us to kind of work our way through. What are your initial thoughts?
I'm kind of thinking this one over. So let's see. So the time course, first of all, it's going on 6 months. So, I mean, sinister things definitely can go on for 6 months, but it's more of like a subacute chronic-ish presentation rather than, oh, this happened yesterday. So that's definitely something to keep in mind. For example, like something traumatic, you know, he wouldn't have pain and swelling for 6 months if this was like some sort of trauma. So that's like the first initial thought is like the time course. and then worsened over the past 2 months. So, okay. And then 7 months ago, he has this hospitalization. So, you know, is this related? Is this unrelated? Is there some sort of more like infectious, inflammatory process going on that could tie the two together? I'm not really sure yet. So I guess those are the initial thoughts that I would have. And then obviously we need more data, but it's kind of tricky. But I like being challenged, so let's see how it goes.
Yeah, Taylor, I love that. You know, I think timing is so informative in this case, in the sense that someone presenting with 2 days of left shoulder and neck pain, you know, we'd be thinking much more along the lines of like trauma, acute musculoskeletal insult. You know, maybe if there was a ton of erythema there, you'd be thinking about, is this like a rapidly progressive septic arthritis or something like that? With 6 months, you know, we can start thinking a little bit more about, well, whatever's going on has been brewing for several months, and how can we adjust our differential accordingly? So, you know, ultimately, even when I think of chronic kind of joint pain, whether it's the left shoulder or the neck, in my mind, the two big buckets end up being, is this kind of more musculoskeletal in etiology, or is this neurologic in etiology? I think the thing that makes me shift that differential a bit here is this past history that Anne-Marie's provided us. So this patient was previously hospitalized, had several small abscesses. He had this cyst in the spleen. There was retroperitoneal lymphadenopathy. Ultimately, it was a sterile abscess. Nothing grew out. That being said, you know, that makes me start thinking, does this patient have risk factor for some sort of chronic indolent infection that is now involving a joint space, or involving a soft tissue of kind of the shoulder and neck region? Then kind of thinking about that, you can take a step back even further and say, you know, are there any chronic medical conditions that our patient is bringing into the last 7 months with him that should influence our differential? And you know, we'll hear a lot more about that in the next aliquot. But you know, ultimately my thoughts are pretty broad. My threshold to, you know, based on where the exam takes us and initial labs take us, my threshold to repeat imaging of that, of not just where he's having the pain right now in the shoulder and neck, but also thinking about imaging of the abdomen, is quite low. Because I think, you know, our patient has shown that in the past, sampling of this abscess has not given us a diagnosis. So based on what the exam shows us and labs show us, you know, will there be something that can ultimately be sampled or biopsied that may get us on the right path if our differential is still fairly broad at that point? So those are kind of the things that are in my mind right now.
Okay, awesome. So the past medical history was notable for poor dentition with past occurrences of tooth abscesses, but no current tooth abscesses. And then otherwise, no known past medical or family history aside from what was mentioned previously. The social history was notable for active tobacco use, as well as previous IV drug use. The last use of IV injection drugs were 2 years ago. Did not like emulsify them and anything like that. Was born in the Northeast and has been as far as Florida and Mississippi, in that area. No travel outside the country, no TB exposures, and then no current like animals or unusual exposures at home. As far as physical exam, the temperature was 37.6 degrees Celsius. The heart rate was 87. Respiratory rate was 20. Blood pressure was 108/73, and oxygen saturation was 99% on room air. Otherwise, as far as exam, the general exam appeared well. The HE and T exam was notable for anosocoria, left pupil meiosis and left eye ptosis, as well as poor dentition with missing teeth, but no notable abscess. And then had a left neck and supraclavicular are swollen and tender, a 3 centimeter firm left-sided supraclavicular lymph node that was tender to palpation with erythema overlying it, and some very small cervical, interior cervical lymph nodes were also palpated. Otherwise, the lungs were clear, the heart was regular without a murmur. The abdominal exam was unremarkable. There was no hepatosplenomegaly. And then the MSK exam showed normal range of motion. And then the neuro exam was normal aside from the previous deficits that were noted in the HE and T exam. And I will leave it there.
What a meaty aliquot, Anne-Marie. That's amazing. Dhruv, there's a lot here. So maybe what if we were to chunk it up first and first cast our attention to the additional context that was provided, and then we can kind of go back to the exam. What do you think about that?
So let's just go back. So we have a young-ish adult with left shoulder and neck pain, chronic with subacute worsening, with loose stools and chills, but not clear whether or not those chills are rigors, and also notable for having a previous hospitalization with liver abscesses, a cystic spleen mass, and retroperitoneal lymphadenopathy, with the abscess returning as sterile, and also noted to have reduced ejection fraction on TTE. So now we get additional context that he has poor dentition, and this poor dentition that was due to tooth abscesses, he also has a history of previous IV drug use, starting to make me think that there might be some sort of endocarditis here, but we'll table that for now. Nothing in the family history, and I think there was a discussion in the chat between Fernan Kushal and myself about whether or not this patient might have had undiagnosed chronic granulomatous disease, but he probably would have been caught by a pediatrician. And then in terms of his other health-related behaviors, nothing in there necessarily that would suggest to me any sort of other infections. Certainly no cat exposure that would make me suggest Bartonella henselae. And allergies, none. So now we move to the exam. And we're seeing here that this is likely neck pain that is referring itself to the shoulder, because he has a tender left neck supraclavicular node. And he also has ptosis and meiosis, and if we were to check his left side, he'd probably have anhydrosis in his left axilla, indicating that he has Horner syndrome, and it's likely due to that left supraclavicular node impinging on the sympathetic nerves. The fact that it's tender to palpation makes me think possibly infection, but can't exactly rule out malignancy. And otherwise, not much else other than the poor dentition that was already mentioned. His BP is, he's it's sort of low, but it's normal enough that I wouldn't I wouldn't think that he'd I wouldn't be concerned that this guy needs to be like admitted to the ICU or to step down. Like he could probably be admitted to a general floor and continue a more extensive workup there.
Drew, that was fantastic. You did a couple of things really, really well. And I love, just to start off is like how you reframed us. Like you did problem representation, like kind of first and foremost, because I think, you, me, a lot of folks in the audience right now are just like, oh my gosh, we're just processing all this data and feel a little bit, at a loss of what to hang on to. So I think by doing a problem representation, going through that exercise up front, that kind of centers us. What I think that we can add at this point is, further elaborating that problem representation, because there's just so much, in terms of context, there's so much in terms of physical findings here that, I think the best return on our investment up front is going to be saying like, can we clarify the syndrome, right? Because the syndrome isn't 100%, exact at this point. It's not 100% defined. And if it's lymphadenopathy, that's really different than if he has a neck abscess, right? So I think that was something great that you did, and just to clarify and sort of highlight that role modeling for the audience, I just wanted to commend you for that. So for those, I'm not sure how many folks have some questions about problem representation, but really I kind of think of it as like a mathematical formula of 3 parts of like, who is this patient and what are they at risk for is part 1. And that's where we get into like, born in the Northeast, traveled through Mississippi, injection drug use, all these different things that could potentially have relevance later on. So that's part 1. Part 2 is what's the timing, which in this case seems to be, again, like an open question. Is like, has the symptoms really been present for 6 months, or is this like a new occurrence on something of an abnormal host? And then part 3 is going to be, what is the syndrome? Like, what is the question that we're trying to answer, or what are we going to Google? And I think that deserves a little bit further clarification in here. So maybe we can start by going through what we have for the exam so far. And I love that you pointed out the, Anne-Marie dropped it and you picked it up immediately, this left pupil meiosis and leftosis, and you suspect she has left anhidrosis as well. So I think you totally accurately identify that as Horner's syndrome. And then the question is like, what diagnostic value does that add to us? So Horner's syndrome can occur when you have some decreased sympathetic activity coming up. And remember, this can be relatively ipsilateral. So it's in this like gosh, I hope there's no neurologists in the audience, but there's this little sympathetic horn in, part of the spinal cord and the thoracic spinal cord that intermediolateral column or something like that, that then sends the sympathetic chain up, and anything that compresses that sympathetic chain or takes out those cell bodies within the spinal cord can give you a Horner syndrome. So I think what this does is it provides localizing information that's probably going to localize to something in the neck, in the lateral neck that's compressing on that sympathetic chain. So I'll give that like a plus minus in terms of like how informative is that. But then we have this question of like, what's that big something there, right? Like, and you pointed out this idea of, is this lymphadenopathy? Specifically, is it left supraclavicular lymphadenopathy? And, I'll pose the question of like, does that point us in any particular direction? Or is that a buzzword for anything that you've heard of?
It kind of made me think of something like a lymphadenitis or a Lemierre's, but the fact that he's presenting more as like a left shoulder and neck pain, referring that way, is a little bit weird to me. Like typically when I think of something like a Lemierre's, I think of it more as this patient has a sore throat that isn't going away. Because Fusobacterium necrophorum tends to give like a strep pharyngitis type of tends to give sort of a pharyngitis type of picture, and that's easily confused for strep. But the other thing too is that Lemierre's is it's typically subacute, but also pretty fast type of subacute. This has been going on for 6 months. This I don't think is Lemierre's.
I think it's great that you're mentioning Lemierre's. We have, the world expert in Lemierre's in the audience with Bob Centaur. So I hesitate to say too much, but, I would say maybe holding off on Lemierre's at this point until we get like evidence of septic pulmonary emboli,
Mm-hmm.
that would be the trigger for me. But what I really like that you highlight is like, oh, is it an infectious lymphadenitis? So whenever you have a lymph node, is it infectious or is it reactive or is it malignant? With the reactive causes most likely being infection or autoimmune disease, right? So, the sort of special buzzword about supraclavicular lymphadenopathy, especially on the left, is that's where the thoracic duct drains. So you drain the lymphatics from the intra-abdominal cavity. So sometimes people will show up with like a first, with a metastatic malignancy with a big lymphatic.
Mershouse node. I forgot about that.
Yeah, no, so that's one possibility, but you're right. Like everything else in this patient, like injection drug use, prior abscesses, like it's red, hot, angry over the top, that makes me think more infection. So basically what I want to know, and what I'm hoping Anne-Marie is going to be able to show us at some point is, I feel like we can't move forward in this case until we get imaging. Is this just lymphadenitis? Is it necrotizing lymphadenitis? Is it a big abscess where he injected into his neck? I feel like that will further clarify the syndrome to the point where we can really get some more diagnostic clarity. So, I just to summarize what we're doing with the syndrome here is it's like, okay, it's located in the neck. The shoulder pain is probably related to that. So I'm going to discount that in my mind and think of them as a lumped thing. And then what I have in terms of questions is, what is this? Is it an abscess? Is it a cellulitis? Is it, a malignant lymph node? Or is it something separate that we haven't really established from our physical exam? And maybe I'll leave it there just with the idea that with the most relevant thing contextually that we've been given is probably this prior injection drug use and this history of abscesses that, I love how you and Kushal are bringing up the idea of chronic granulomatous disease. And just for the audience, the thought process behind that is it can be diagnosed in young adults, and it often presents with staph liver abscesses is kind of the kicker there. And I'll refer people to my new favorite podcast besides the CP Solvers is Febrile, a cultured podcast where they bring up a case of chronic granulomatous disease in somebody who had a staph liver abscess, or at least they talk about it.
Yeah, and just a couple more things to add on to that. One is that that was my med peds brain talking when I brought up CGD. But the other thing too is that, and I guess this is a question that I'm going to pose, is tender lymphadenopathy necessarily indicative of infection over malignancy, or is that something that we cannot, or can we not rule out malignancy right now with any sort of certainty until we get imaging?
The thing, Drew, is, there's all these rules that we learned in medical school. And I think as you go forward and intern year residency, and you'll learn that a lot of the rules are broken, you'll hear the buzzwords of like, oh, it's fixed, firm, non-tender, being suggestive of malignancy, but then you see every variation under the sun. So, just in terms of like diagnostic, keeping our diagnostic brains kind of open, I would just say, oh, it's lymphadenopathy, maybe, one, if it is lymphadenopathy, then I would say, what's my differential there? And then still go through the sort of diagnostic testing algorithm rather than discounting something because, maybe it's a little bit more tender or something like that. But I agree with you, like right now at this point in time, like infection still is towards the top.
Awesome. So just to give you some laboratory data, the WBC was 14.6 with a neutrophil predominance. There was no significant lymphopenia or eosinophilia or anything like that. The hemoglobin was 12.6 and the platelets were 387. As far as the chemistry, the sodium was 135. The potassium was 3.6. The chloride was 104. The bicarbonate was 28. The BUN was 12. And the creatinine was 0.6. The glucose was normal. Calcium was 8.6. Albumin was 3.2. Total protein was 6.9. And then the AST, ALT, alk-phos, and bilirubin were all completely within the normal range. CRP was 48. LDH was 137. Urine toxicology screen was negative, and TSH was normal. The imaging of the neck and soft tissue showed inflammatory changes within the sternocleidomastoid scalene in left supraclavicular fossa with multiloculated confluent peripheral enhancing fluid collections in the left supraclavicular fossa. And then there was also the lymphadenopathy as well. And then, and that was done with contrast. And then the CT of the chest, abdomen, and pelvis with contrast showed the above changes, as well as heterogeneous fluid collections in the left chest wall and liver and spleen with central necrosis. And then several irregular scattered pulmonary nodules at the left lung, with the largest being 1.4 centimeters in diameter in the lingula.
All right, Taylor, the plot continues to thicken. Where does this aliquot of information kind of guide you in terms of what's been discussed by Dan and Drew previously, and how we can kind of build on that?
Yeah, the discussion was great. I want to just say that I think I only heard of Lemaire's disease either from this podcast or because my boyfriend's an M2 studying for STEP, and he might have mentioned it because STEP loves all of these really like obscure things that I've never heard of. Just wanted to mention that. But yeah, the discussion was great. I definitely agree with what everybody's saying, just kind of going back to like the initial presentation and chief complaint. We can obviously say this probably isn't trauma, this probably isn't gout. It's definitely something more systemic. And then kind of trying to narrow down like the next steps from there. Was really great to hear you guys discuss. And I definitely agree. So based on the labs, he has a little bit of a leukocytosis. He's a little bit anemic. I think 12.6 is a little low for a male. And then I think his platelets are normal. And then going on to his chemistry, I kind of am like half trying to read the dictation and half the chat. I don't know if because you gave us a total protein, I need to calculate the protein gap or whatever. But if I needed to do that, I would need to be reminded how to do that. I'm not sure if MD Calc has a calculation. They probably do. But regardless, I'll go back to that in a second. So his chemistry, I don't really see anything too outstanding, just like at a first glance. And then his CRP, I think 48 is high, as well as 137 for the LDH. I think that's also high. So that lets me know there's, some sort of inflammatory process going on. And then onto the imaging. So his CAT scan of the neck. So these like fluid collections that are seen both in the CT of the neck and also the CAT scan of the chest, abdomen, pelvis. I guess, is that something infectious, inflammatory, something autoimmune? Maybe I would like discuss with the radiologist or something if I was, the PA getting the wet read and seeing what they thought the differential could be based on what they're seeing. And then the pulmonary nodules are interesting. This also goes along with like the differential of something infectious, something inflammatory, something autoimmune, because sometimes like one pulmonary nodule is sometimes nothing, but I think several probably indicate something is going on. So I think like the next step is probably like something has to be biopsied. And what that is, I'm not sure, but you know, a biopsy would give us a lot more information and help us narrow the differential down. Maybe they would go for the lymph node. I'm really not sure. And then let's see. So is the protein gap elevated? Can someone just tell me quickly? I know it's like 4 minus albumin or something.
Yeah, so the protein gap is total protein minus albumin. For this patient, it's 3.7. There isn't kind of a hard and fast as to what an elevated protein gap is. I kind of use a cutoff of 4, so a protein gap greater than 4 makes me kind of think about it harder and whether we have a way to explain it. But some people will say, you know, if it's any more than 3.5, that kind of makes them pause for a second. So kind of right on the edge there.
Okay. So either way, like a protein gap can be elevated, I think, in like some sort of sepsis picture. I've seen that on patients I've taken care of, or it could indicate like some sort of like multiple myeloma or some sort of like extra gamma globulins coming from somewhere. Or I think like nutritional deficiency can also have a high protein gap. And now I'm like honestly thinking about who I would consult, because I tend to consult a lot of people. I don't know. I don't know who I would start with, just because this is so broad and I'm still not quite sure what I'm leaning towards in terms of the differential of being like infectious, malignant. So those are kind of my thoughts, that I would want a biopsy of something, and then I would need a consult or more than one to help better take care of the patient.
Taylor, I love how you walked through like a ton of information and basically like distilled it down to the most important parts, which is, you know, what is it that we're worried about and how are we going to work it up? I also love that you had talked about how, you know, if this was a patient that was right in front of you, you'd be talking to the radiologist about those images and kind of being able to look through them with the radiologist. I think that's something that's so important to be able to do in a case like this, where you're able to provide the clinical context, and that can in turn help the radiologist give us the best read that we need to kind of move forward. So taking a step back, I'm going to start with the CBC and work my way through. So this patient has a mild leukocytosis that's neutrophil predominant. So there's no mention of any eosinophils, which is reassuring. It makes me less worried about either eosinophilic vasculitides that could potentially be causing things like cavitary lesions, or infectious causes that are typically eosinophil predominant, whether that be atypical parasites or fungus or something like that. The hemoglobin is a little low, you're right. I wonder if this patient has some degree of anemia of inflammation, given the quantity of time this has been going on for. Platelet count is normal. So I won't dwell on the CBC any more than that. Moving to the Chem Panel, I agree. There's nothing that really jumps or screams out to me about the Chem Panel other than maybe this borderline protein gap. And just based on everything that we know, normal renal function, a hemoglobin that's only very mildly decreased, you know, I think my pretest probability for the protein gap being from something like a polyclonal gammopathy, so like a chronic inflammatory process that's causing a protein gap, as opposed to a malignant cause like multiple myeloma, is pretty high. Like, I don't think an SPEP is going to give us the answer here. So I'm not too, you know, I'm not too fixed on chasing down this protein gap. I think there's much better next steps in workup, which you've already laid out. And then we get to the imaging. So here we have multiple sites involved. So you've got this neck that has this multiloculated abscess fluid collection. There's associated lymphadenopathy. There are inflammatory changes in the sternocleidomastoid. So, you know, having been, I see a lot of imaging as a hem-onc fellow, and, you know, given the referral bias of being a hem-onc fellow, most of the time it's malignancy. It's very rare for malignancy to kind of get into the muscles and cause inflammation of the muscles and things like that. You know, that makes me worry much more so about an infectious cause than a malignant cause. Then we get to the CT of the chest, abdomen, pelvis, and you can see that if this is an infectious cause, it's something that has disseminated. You have fluid collections in the chest wall. You have pulmonary nodules. The spleen has fluid collections that are necrotic. So with all of that in mind, you know, then I start thinking about, if this is something infectious, how is it spreading? And we do have this history of a reduced EF on an echo a handful of months ago, and IV drug use. So my threshold to not just try and sample that fluid that's seen in that multiloculated fluid collection, but also get a TTE, potentially a TEE, and then draw 3 sets of blood cultures to work up infective endocarditis I would want to do those things kind of in parallel, because infective endocarditis is one of those things that if you have kind of multiple sites involved by an infection, infective endocarditis is definitely something that should be on the differential. So, you know, I don't have a firm diagnosis. Like I can't say this is the bug that I think that's driving all of this, but with this aliquot of information, infection, and, you know, some sort of chronic infection that is now kind of disseminated to multiple sites is rising kind of further and further up my differential. And that's what I'm most worried about. I think the other thing that we have here that's very reassuring is I think we have the luxury of being able to sample either fluid or tissue before we start empiric antibiotics, because this patient is hemodynamically stable. So we don't have to worry about, you know, throwing broad spectrum antibiotics at him and then sampling something, not having a bug grow out, and then think about, well, you know, did antibiotic exposure mask that? He did have flagell, but that was now several months ago. So I would think that if this is all being driven by infection, hopefully sampling either the lymph node or the fluid would tell us what bug we need to worry about.
Okay, on that note, workup included multiple sets of blood cultures before antibiotics, which were negative, HIV, which was also negative, a quant fold, which was negative, Bartonella, Henseley, and Quintana, IgG and IgM were negative. Toxoplasma serology was also negative. RPR was negative. And then a urinary histo antigen was negative. Autoimmune workup, including ANCA, and then total IgG and subclasses were unremarkable. Repeat TTE showed a normal EF without evidence of valvular lesions. And then an excisional lymph node biopsy was performed, which showed necrotic tissue, but was otherwise unremarkable. And aerobic and anaerobic cultures, fungal and bacterial cultures, and AFB from that remained negative.
A whole lot of negative.
Yeah. So, yeah, a lot of it is basically just telling us either no or not giving us an obvious yes. So blood culture is negative, HIV negative, which reassures me. Bartonella, IgG, IgM negative, which, given the case that I most recently presented, isn't necessarily indicative that this patient doesn't have Bartonella. Toxo negative, RPR negative, urinary histo negative, ANCA, total IgGs and ANCA's negative, total IgGs and subclasses are normal. His TTE has gone back to normal. That's a good thing. And then what else? Other than that, tissue, I guess, wasn't the issue. it basically just showed necrotic tissue and nothing else. Yeesh. At this point, if it were my ID friends calling, I'd go and I think this patient deserves Carius, or basically shotgun PCR of essentially cell-free DNA to try and figure out exactly what in the world he has. Oh, and forgot that this is also that he's also TB negative. So yeah, this is probably going to break the bank, but Carius, please.
Yeah, I share a lot of the consternation so far at this case. Good consternation, Anne-Marie. I'm loving this case, but yeah, I'm also a little bit at a loss. But I might suggest, Drew, that at this point we could like reframe this, right? Like our problem representation is like a young guy who has a history of injection drug use, traveled throughout the United States, southeastern United States. Coming in with what appears to be chronic sterile abscesses and necrotizing lymphadenitis. How's that sound?
Chronic sterile abscesses and necrotizing lymphadenitis. Oh, goodness.
Or culture negative infection. That's another sort of like thought process that we could go through.
Yeah, we could. And now that whole discussion about chronic granulomatous disease is starting to come back up again. And yeesh.
Why don't we start?
I'm still trying to. Nope.
No, you go ahead. Sorry.
I guess I'm still biased to trying to find a bug at all costs before going down any sort of other road.
Yeah, and I think that we can still think through that. So how do you think of, and maybe we can like build a schema together, kind of brainstorming, is like something that's culture negative, a culture negative abscess or a culture negative infection. Like how might we get to, this sort of lack of informative blood cultures or, fluid cultures? I guess maybe the first way is like, okay, let's hypothesize that there actually is an infection there. How can we get negative cultures at that point?
So it's either you don't have the right culture conditions for the bug, you may have given antibiotics already and treated the bug, but it dies, so it dies too rapidly and you don't get anything, or it's not an infection at all and you're dealing with something else.
Yeah, I think that is pretty much most of the stuff on my list is. Were there antibiotics? Anne-Marie was very specific to tell us that there weren't antibiotics prior to cultures in this case.
Mm-hmm.
Is it something very difficult to culture? Like you mentioned, like, do we have the wrong media? Anaerobes in themselves can often be difficult to culture, but like this widespread of an infection, dedicated anaerobic culture is like that sort of starts to beg credulity there.
Yeah.
Next, is it, not a bacteria? So she mentioned histo. A lot of I imagine fungal cultures were sent on this. I imagine, atypical bacterial cultures like AFB were sent on this. And then lastly, perhaps where this might be going, is non-infectious causes of what appears to be these abscesses, right? So, maybe we can just kind of take off the idea of like, oh, antibiotics were given first. So then we have what are difficult to culture sort of things. And there are a number of bacteria that are difficult to culture, anaerobes being kind of the biggest ones. But again, I have a hard time believing that with, the amazing infectious disease workup that Anne-Marie's colleagues have done, that they couldn't get, between the abscesses, between the lymph nodes, between the blood cultures, that they couldn't get something to grow in the absence of antibiotics. Any other bugs jumping up to your, in your mind of like, oh, this is going to be something that's really hard to culture that is a pyogenic bacteria?
I mean, maybe NTM, but I wouldn't think that it would be. I would think that it would cause more granulomatous disease rather than these sterile pyogenic abscesses.
Yeah, and I think that's a great addition, right? So then if we go to like atypical bacteria, is it a mycobacterium? So in TM disease, like for this to be a non-tuberculous mycobacteria, this would have to be disseminated non-tuberculous mycobacterial disease, right? And so far we think that he's relatively immunocompetent.
Right,
So,
he's HIV positive or HIV negative.
Yeah, he's not on mycophenolate. He's not getting exogenous immune compromising medication. So overall, I think that we can bring that down just because, you don't really see disseminated NTM disease frequently in immunocompetent patients. If you see it, you'll more likely see it in folks who are like dramatically immune compromised, like Anand might be seeing on his heme BMT sort of service. Then in those situations, you can see like a necrotizing paniculitis. It kind of looks like erythema nodosum. There was a great case on CP Solvers in its original, in its kind of early season, I think, where they talked about that. So yeah, is it NTM? Probably not. Is it tuberculosis? All that we've been told so far is that he doesn't necessarily have risk factors and that the quantiferon was negative. So, quantiferon being negative for diagnosis of active TB disease is kind of, it's a bit of a nothing burger. Because if you are sick with TB, the quantiferon just, assesses your prior exposure, and it's kind of a flawed test in assessing for active TB. So really what I would want is like AFB blood cultures, AFB cultures off of the lymph node, off of any tissue that you can grab. So that's possible, right? It's not super likely, but it's possible, especially given that we have maybe some, lung nodularity, and, there's perhaps going to be a question coming out later of some other exposure that we weren't, privy to earlier in the case. So that's a possibility. You always have to think about TB. It can do virtually anything. And it certainly can do necrotizing lymphadenitis. Okay, so other fungal stuff. She told us, or moving on to fungal stuff, she told us negative urinary histoantigen. This is a part of the world, and again, I'm not the world's greatest with that geography of that part of the country, but like could it be another endemic fungus, right? So basically one of my fungal diseases is an endemic fungus, which, most of them come in through the lung, and then if they disseminate from there, right? So
this is histoblasto territory, although the Northeast typically doesn't have very many. Although then again, I think there is the whole thing of histo is, you can't really class it as an endemic fungus or endemic mycosis anymore because histo is everywhere. It's more of an epidemic mycosis.
No, that's a great point. That histo can be found throughout the United States, including here in California. But typically, if you have disseminated histo or disseminated blasto, they kind of map onto a little bit different of a syndrome. Like blasto tends to have cutaneous lesions. We haven't been told about that. Histo tends to have gastrointestinal or bone marrow or reticuloendothelial cell kind of manifestations. And again, I'll just refer to I think the first time Bob Centaur was on the podcast, he discussed an awesome disseminated histo case. And he dropped a lot of pearls with that one. So is it histoblasto? Maybe add more testing for blasto. I would add additional testing for histo, just because like the urinary antigen, while it's a helpful, easy to get test, is not the end all be all. So typically you'll send serologies, urinary antigen, sometimes definitely cultures the blood or whatever tissue you're sampling. And the same for blasto. That it doesn't sound like the patient's in a cocci territory. This wouldn't be the world's worst story for cocci if they had the risk factors. That can certainly do soft tissue abscesses. And Candida can do liver abscess. Candida can do kind of disseminated infection, but grows on blood cultures. So I think it's going to be less likely Candida. And then a lot of the other molds and kind of more rare fungal things that we'd think about, they typically won't occur in an immune competent host. Are there parasites that can do something like this? Maybe. Not the greatest story for parasite. I don't typically think of a lot of parasites doing abscess sort of formation. You could get cystic disease with like a echinococcus, but I don't think abscess, perennial abscess like these. Amoebiasis, if it was just the liver stuff. But again, I don't think that with the neck and soft tissue findings, we necessarily think of that. Okay, so then we're left with non-infectious. What do you think for non-infectious here?
At this point, this is where my differential starts to peter out, and I start thinking of more weird things. So, yeah, CGD is one, but oof. It could be something like a sarcoid, or especially considering that he has those pulmonary nodules. But it would be kind of weird to just present itself as a multiple sterile abscesses in a necrotizing lymphadenopathy. Usually it presents itself as a granulomatous disease. Yeesh.
What about malignancy?
I'm not really feeling malignancy either, weirdly enough.
Yeah, I mean, it's tough. You know, you think that with all this imaging, they would have found a primary. I will say people this age, you know, 30-year-old male, could they have like a testicular, like a germ cell tumor that the primary is like outside of the field that they would scan? You know, I'm not as familiar with like the manifestations of germ cell tumors, but certainly when you think like necrotizing lymphadenitis, it's cancer, it's TB, sometimes it's vasculitis, sometimes it's, you know, some rarer things like Kikuchi Fujimoto disease. But I would wonder, like, should an AFP beta HCG be sent on this patient? Should there be a testicular exam? So basically that's a long way for me to say, like, I don't know where this case is necessarily going. I like your idea of like universal PCR, doing some of these other more advanced molecular testing. But I would say, you know, negative cultures like brings up this question of like, could it be something non-infectious? And, you know, I'm wondering if that's the direction that the case is going, with, you know, germ cell testicular tumors being perhaps one of the more common ones in 30-year-old males. You know, could he have another tumor somewhere? It's possible. But again, my degree of certainty isn't super high. What other thoughts do you have, Drew, before we turn it back?
I think I am waiting for I'm waiting for there to be a very long scratch on one of his arms.
Let me just since it's getting later, give the last aliquot of information.
Yeah,
if that's okay.
Please.
Was discharged with augmentin and close infectious disease and ENT follow-up. In the interval since hospitalization, had been off antibiotics for 2 months, underwent a repeat core biopsy. So this one was not excisional, but core of the left cervical node, which showed prominent acute and chronic inflammation with necrosis and fibrosis. Bacterial and fungal cultures from that remained no growth, as well as AFB culture. Did receive a 10-day course of steroids that maybe improved his symptoms a little bit. Followed up again in clinic. It's now been 3 months since that hospitalization, and is now having some low-grade fevers, some drenching night sweats, and increased fatigue and myalgias and arthralgias. His adenopathy has worsened, and his neck pain is now worse as well. And he continues to have left eye droop without significant visual changes. And then, like, now if you see a picture, it's like very large visible lymphadenopathy in the cervical chain. Let me see if I can. Sorry, I don't have it on the computer image. I don't know if that's visible at all.
yeesh.
And then the next aliquot will reveal the diagnosis.
Anne-Marie, one quick question. Do you know if flow cytometry was ever done on either of the 2 lymph node biopsies?
I am not sure about that. I am sorry.
No worries. The reason I ask, you know, so whenever we're looking at lymph nodes, especially when there's necrotic tissue and it's very hard to tell the architecture of what's going on in those nodes, if you're able to do flow and kind of get a sense of, are the lymphocytes that are tracking there, are they B cell predominant versus T cell predominant? Are they monoclonal versus polyclonal? That may give us some hints as to whether we're thinking more malignancy versus an inflammatory infectious cause. So that's something that sometimes can help tease out a very difficult case like this. Given that it's the last aliquot, and we're now quite a few minutes past our hour. Why don't we all, myself, Taylor, Dan, and Drew can kind of give a quick sentence about where they think things are headed at this point, and then we can turn it over to Anne Marie to bring us home, and then get teaching points from Gerline. But yeah, Taylor, we have a ton of information. And we know that the next step is going to give us the diagnosis. What would your next step be? What do you think you would try to do for this patient next to try and get to the bottom of what's going on?
Yeah, so first I'll say, like when Drew was talking, I kind of agreed that at first, like I wasn't super, like malignancy wasn't like top on my mind, just because at first he was denying like night sweats, he was denying fevers, and then like his labs, if there was some sort of, like lymphoma process going on, I would assume like maybe more of like his like CBC may be abnormal. Actually, that's probably more leukemia that I'm thinking of. But either way, the lack of more like systemic symptoms didn't really, that's why malignancy didn't really like scream out at me. However, now he is endorsing like fever, night sweats, worsening of his lymphadenopathy, worsening of, I guess, like this Horner syndrome going on. So some things obviously like getting bigger, and obviously nothing's resolving, right? So steroids improved a little bit. He had a short course of antibiotics. So, if it was like an easy infectious thing and he got antibiotics, you would think that he would have gotten better, not worse. And then the steroids are kind of like not too telling, like maybe he didn't get a long enough course, something like that. So I think the next step, I would want a repeat biopsy. That's what I want.
No, I'm with you. I think trying to go after another.
Oh, he did.
Oh,
He
sorry.
had a repeat biopsy. Sorry, I missed that.
No worries. I was just going to say, ultimately you have to start thinking about, if we keep getting necrotic tissue, do we maybe need to biopsy something that's not in that supraclavicular area? Because he has, on previous imaging at least, he's had other adenopathy that's been noted. So if there's somewhere else that's accessible, it almost may make sense to go away from the spot that we've biopsied in the past. So that would be what would be on my mind is getting more tissue, like you said, but almost thinking about going somewhere that's not in the neck. And I agree, at this point, malignancy, something like lymphoma is very high on my differential. And then Dan had mentioned some of the more kind of rare causes of necrotizing lymphadenitis, like Kikuchi's disease. So, we start really getting into the very rare things. And I think, yeah, tissue is where the answer hopefully lies for this patient to ultimately come to a final diagnosis.
Agreed. And now that he has the B symptoms, I'm starting to think that this is this is looking to me more like a lymphoma of some sort, whether it be Hodgkin's or DLBCL. And I guess as a follow-up to that, try to find a spot where we can actually get some tissue that's not the neck. It's a bit risky, but I'd say if he has, I'm trying to remember if they did a repeat CT of the abdomen and if he still has that retroperitoneal lymphadenopathy. And if he does, that could be another area to check.
Yeah, and I'll just add, I think it's still super broad. The longer this is around, though, the less likely most common infectious causes tend to be. So I think at this point, sometimes people will consider doing like a FDG PET to just kind of see the distribution of like inflammation and in cases of like FUO. This isn't exactly FUO, but it's kind of like inflammation of prolonged, unknown origin. So I might consider doing a PET followed by like an excisional lymph node biopsy. for which you send like universal PCR, metagenomic next-gen sequencing, all the flow and stuff that Anand is expert at. And then, just probably adding on, I'm not sure if this was done, like weird atypical bacteria like Brucella, Q fever, Bartonella again, just, to double, triple check, and then consider like, oh, has this patient ever had doxycycline is something. But, I think the longer this goes on, the less likely infection is, although I'm very ready to be surprised by Anne-Marie.
Awesome. Well, an excisional lymph node biopsy of the neck was performed again that showed some atypical stains that stained positive for CD15, PAX5, and CD30, and negative for CD3 and CD20. Additionally, some rare Reed-Sternberg cells were seen as well. And so the final diagnosis was Hodgkin's lymphoma.
Wow. I knew the last time I saw a Hodgkin's case, Farnod presented one, but God, this racked my brain. Yeah, okay, and this patient is probably going to be getting ABVD and radiation after this. Dang.
You could correct me if I'm wrong, but I actually had a patient who we diagnosed lymphoma on. And isn't it that you can only perform a certain type of biopsy to diagnose it?
Yeah, no, you're 100% right, Taylor. So fine needle aspiration it will almost never give you enough to diagnose lymphoma. And that's actually one of the things about this case that's so interesting is all of the biopsies were really good samples, so there was an excisional done, a core, and then a third excisional. So it's not like the reason that we didn't get to the diagnosis was because an inadequate biopsy was done. It was just we were getting lots of tissue that was necrotic. And I think I really want to commend both you and Dhruv for kind of sticking with your gut in the sense of continuing to chase after the tissue that we thought was involved, and as things were coming back negative, being able to kind of shift the diagnosis towards something that may no longer be infectious. Hodgkin's and disease and lymphoma in general can be incredibly humbling, and again, there's a little bit of a referral bias in the patients I've seen. Most times they already have a diagnosis in hand, but you get a chance to hear their story in terms of how they ultimately came to this diagnosis of lymphoma. And there are some pretty strange stories as to how people ultimately get their diagnosis of lymphoma, and whether it's a third, a fourth, a fifth biopsy that sometimes is what tells you what's going on. I think the great news for this patient is that we live in an era where Hodgkin's disease is a very curable lymphoma. So that's some good news there.
Amazing case. Thanks so much, Anne-Marie, and great job to Taylor and Dhruv. Very amazing, interesting case. I wouldn't have. I'm going to add this to my sterile abscess illness script. So, will you turn it over for teaching points at this point?
Yeah, thank you so much for this case. It was really humbling discussion, and there was just so much going on. I'll try to summarize some of the key takeaway points that I took from the discussion. So when we started off here, we had the chief complaint was shoulder and neck pain. So when we're thinking about this chief concern, we're really trying to frame it in terms of the time course. So if it's more acute, we're thinking more things like musculoskeletal and trauma. In this case, the symptoms were more subacute to chronic. So we can think about musculoskeletal versus neurologic, but also think about anatomically. There might be other things irritated in that region that can cause referred neck and shoulder pain. So whenever we're trying to frame the patient and the clinical syndrome, we can create a problem representation and see how that adapts and changes as we get more information, and how that guides our hypothesis generation and our diagnostic reasoning. So when we're thinking about the problem representation, we're thinking about who is this patient in terms of age and pertinent past medical history, and then what is this illness or the clinical syndrome, and that incorporates the time course and the key symptoms. So in this case, in the beginning, we had some evidence of inflammation given the chills and some of the systemic symptoms, as well as the lymphadenopathy. So when we're thinking about inflammation overall, we use the IMAID mnemonic, so infection, malignancy, autoimmune, and endocrinopathy. Other things that would clue us into funky inflammation would be things such as eosinophilia, isolated leukopenia, so looking at the labs to help diagnose and further figure out what route we want to take when we're considering the patient. And then in this case, the clues of the myositis was assessed to be Horner syndrome. So this wasn't too relevant to this case, but I just thought it was a nice review of Horner syndrome overall. So when we're thinking about Horner syndrome, thinking of an anatomic approach. So Horner syndrome is due to problems with the sympathetic chain. So your first order neurons go from your hypothalamus to your intermediolateral cell columns. So if there's anything interfering with the intracranial side and that affects the primary order neurons, that can cause a Horner syndrome. And then the second order neurons go from your T1 spinal cord to your cervical sympathetic chain. And then they go to your superior cervical ganglion. So things such as a Pancoast tumor or lymphadenopathy in that area can also cause Horner syndrome. And then the third order neurons follow the carotid artery. So anything in that sense, like a dissection or aneurysm along that artery can cause Horner syndrome as well. So when we were approaching this patient, the main thing was the lymphadenopathy. So when we're thinking about lymphadenopathy, thinking about the timing and the location, and then thinking about in terms of reactive, is it due to infection or due to malignancy? And then in this case, there was a lot of negative findings. So using those absence of things to further guide reasoning. So there was no eosinophilia. So that helped guide us that we weren't thinking about certain atypical infections. And then the systemic nature of inflammatory changes that we saw in this patient that were more, there was inflammation in the muscles, that is more likely with infection compared to malignancy. But the fact that continued cultures and everything was coming back negative, and that the syndrome progressed with systemic V-like symptoms, that made us shift our hypothesis and pivot from our previous consideration of infection to considering more malignancy. And then when we're thinking about no improvement with antibiotics and other treatments for infectious things, we're thinking about the W. So is this the wrong diagnosis? Is this the wrong bug? Atypical infections such as TB or things that are difficult to culture, or is this the wrong drug? Are we not penetrating the tissue that we're trying to treat? And in this case, it was specifically necrotizing lymphadenitis. So when we're thinking about necrotizing lymphadenitis, things like infectious things like TB, in this case, that was less likely because this is an immunocompetent host. So framing our hypothesis is important based on the host and what we're thinking is going on underlying. And then other things causing necrotizing would be lymphoma or malignancy, like was in this case. And then other rare diagnoses include non-infectious causes like Kikuchi's disease, which has isolated unilateral cervical lymphadenopathy. Thank you so much for the discussion. It was really great today. And I think I have to rewatch and re-listen to kind of process what went on.
Thanks everyone for joining us, and thanks Darlene for wrapping up 80 minutes worth of discussion into like a power-packed 2-minute rundown. So yeah, thanks everyone for joining us, and hopefully we'll see you all again soon.
Take care, everybody.